on video view? Okay.
You
All right.
remembered.
Okay. Yes, you remembered.
Oh, look, we have lots of people joining. Hi.
We're a little bit informal here. We keep learning again and again how to do this, even though we do it a lot. So I want to ask Melissa to start off and talk about HealthCurrent and what has occurred in the last year with her organization. Melissa.
Great, thank you, Scott. I appreciate the opportunity to be here this evening to talk with you all. I see a few friendly faces. As Scott mentioned, Pedro, Scott, and I served on the Valleywise Community Health Centers Governing Council for multiple years. So excited to talk with a different group that Scott's engaged with. So our organization, HealthCurrent, let me just give you a little background and overview. We're a statewide nonprofit organization. We serve as the statewide health information exchange. And if you're not familiar with what that is, we basically connect the electronic systems of healthcare providers, hospitals, and systems across the healthcare spectrum to share clinical patient information for the purposes of ensuring that healthcare providers and other authorized healthcare individuals have access to as complete as possible patient medical history. So we have been, HIE in Arizona really dates back over a decade. And it's really in the last 5 to 6 years that we have grown exponentially as an organization. But today we connect electronically the hospitals around the state that represent 98% of the statewide discharges. We connect electronically virtually all of the federally qualified health centers. We have health plans participating with the HIE, accountable care organizations. We share general physical health, general mental health, and substance use disorder information. So we really span the spectrum of physical and behavioral health information. We have the likes of behavioral health providers, emergency medical services, long-term care. And the goal is really to have these electronic systems connect to our statewide platform that allows information to be available longitudinally on patients so that care can be, information can be accessed at the point of care. It can be accessed for public health purposes, for population health and analytics. And today, because we've grown from 75 organizations participating with the HIE at the end of 2015. I just got our updated statistics today. We have over 875 healthcare organizations participating in the HIE. And a healthcare organization could be as large as Banner or Dignity or Honor Health, that's one participant, or it could be a one doc practice, could be one participant. So 875 organizations really represents over 10,000 healthcare providers. So we have connections to over 250 of those organizations for real-time data sharing. And we have data available on over 13 million individuals. So I know we're gonna talk a little bit more later about how we've been able to support the community in the COVID pandemic. But for instance, some of the types of services we provide today is that if a primary care provider or community health center wants to be aware of, and better coordinate care for their patients and know when their patient goes into the emergency department or is admitted to the hospital to help coordinate their care, that data comes from the hospital to the HIE in real time, like within seconds of when it's entered into the electronic health record. And we can route that to the federally qualified health center, for instance, like Pedro's organization, if we know that that patient regularly gets care at Adelante. So we've got a system that allows for real-time data sharing and real-time provision of alerts. And we also have a portal that allows for access to longitudinal data. And we work closely with the healthcare organizations across the state. We work with Medicaid agency, and we have a long-standing, strong relationship with Access. We've always worked with the Department of Health Services and really have probably quadrupled our connections to public health in the pandemic because we had a good foundation built, and we provide a variety of services. So That's a high level overview. I don't know, Scott, if you want me to start talking about COVID-19 or allow Pedro to give an overview and then we can get into the discussion.
Yeah, we'll let Pedro introduce Adelante, and then we'll move on into the COVID-19 arena.
Thank you, Scott.
Okay, Pedro, you see.
Thank you, Scott. Thank you for the invitation this evening. We are definitely honored to be here with you all this as well. You know, Melissa, we go way back, so it's a pleasure to be on a panel with you again. You know, a little bit about Adelante, Scott, is Adelante Healthcare has been around here in the Valley in Arizona for the last 40 years plus. We were founded in 1979 in the small area of Surprise, and really serving our migrant communities out there in our farm working, you know, communities as a small community health center, you know, making sure that individuals were, you know, receiving that holistic care back in those days and the treatment, physical health treatment that they needed at that time. Since then, we've really grown as an FQHC, a federally qualified health center here in Maricopa County and in some of the rural areas, to now serve over 75,000 individual unique patients with over 235,000 patient visits on an annual basis. We have 9 comprehensive sites here in Maricopa County, Gila Bend, Wickenburg, which are, believe it or not, those are all Maricopa County. But they're out there in the rural areas, right? And so you know, we definitely have, you know, our locations spread out through Maricopa County and serving our community in that way. But then we also have additional individuals that we serve here, and we have over 176,000 WIC visits on an annual basis, which is women. And so when you compile that with our outreach into our communities, we're serving over 450,000 individuals on an annual basis, which is truly, you know, unique and amazing for our FQHCs. You know, Scott, you had asked, you know, in an email, you know, come with a fun fact, right? And I wanted to share one with you, and just it highlights the value that community health centers bring to our country. You know, the fun fact is that what people don't realize is that, you know, we have over 250 million, you know, U.S. citizens in the United States. All health centers, community health centers across the country serve 10% of that population. But you wouldn't think that because you're thinking about all the other primary care centers. And so it's just a nice little fun fact. It's one of the reasons why the CDC has allowed us to get some of the vaccinations, you know, directly from them so that we can administer those. But just to highlight, I know we're going to get into details about, or you know, I want to share more. But the services we provide at Adelante are internal medicine, family medicine, pediatric care, geriatric care, dental services, behavioral health services, really looking at, those are our comprehensive sites. And it's really that whole gamut of healthcare, also looking at the social determinants of health and bringing in those additional resources to impact, you know, food insecurity, housing, and so forth. And so it's about how do we bring that comprehensive approach to serving our community and really impacting health outcomes associated with our population. You know, Adelante serves and cares for communities that are underserved, and that is ultimately why we exist and why we are here. So
you serve 77,000 people in Maricopa County, right?
Yes.
How in this era do you reach out and get people to trust being able to deal with COVID-19?
You know, it is very important to trust, and you know, something that we think about, we talk about as an organization and do, and that's actually going out into the community and being present. When we have an event in Aguila and, you know, it's working with farm workers who are maybe a little apprehensive to coming in and getting a COVID-19 test, or for that matter, even thinking about getting a vaccine test, you know, I personally am out there with my staff and people that look like them and can speak their language, you know, builds trust. And you know, we also volunteer at other events so that we can help other pods build that trust as well. We recently went out and volunteered at Arizona Complete Health pod at the Phoenix Municipal Stadium, and they had a great deal of individuals out there. We had multiple organizations that that serve different demographics in our community. But ultimately, it's how do we respond and act and be present as a community is the beginning of building trust. And of course, being able to speak to individuals in their language, providing information that is valuable to individuals. There's a lot of questions and concerns that our communities have around just the pandemic in general.
And the fact that they're here in Arizona, where it has not been very hospitable towards Latinos. Melissa, I'm just curious how your numbers or your systems get reports or information about the migrant community, about different communities, and what you learn about the social determinants of health.
Sure. So today we exchange primarily clinical information from electronic health records, from lab information systems. But one of the key things we've been able to provide in the pandemic is because of our systems basically assemble records from all different places. We have what's called a master patient index that collects patient demographic information, and it assembles a Scott Jacobson record from this facility over here with the same Scott Jacobson record with this facility over here. And it brings them together and makes them part of the same record. That actually has helped from a patient demographic standpoint in the pandemic. First of all, because we have better race and ethnicity data on patients across Arizona as a result of assembling so many different medical record systems. We have a better chance of having complete and accurate race and ethnicity information. So that's helped in the pandemic because those patient demographics have been largely missing, especially in the COVID-19 lab area. Then when it comes to social determinants, I was mentioning to Scott earlier this week, we actually have recently announced our selection of our technology platform and our launch this year in 2021 of a statewide social determinants of health closed loop referral system. And what that means is that certainly community-based organizations and social service agencies have long coordinated the needs for the population when it comes to food insecurity, when it comes to housing assistance, when it comes to utility assistance, et cetera. But it's been more and more acknowledged within the healthcare community that those social risk factors significantly influence health and wellness. So there's been a concerted effort in recent years for healthcare providers to do a more robust job of surveying and assessing when patients have needs in those areas and being able to connect them to resources. The challenge is the connection to the resources and making sure if you make a referral to someone to provide housing assistance or to a food bank, that they actually went there and got the service and they were taken care of, at least at that point in time. So in collaboration with Access, also in collaboration with the Arizona 211 program, HealthCurrent has been funded with Medicaid support to procure and implement a statewide technology platform that allows those assessments of social risk factors and social determinants of health to be uploaded into a referral system to connect the patient, the individual, with the necessary community-based organizations and social service agencies that can provide them help, and then actually track that referral through the technology platform so that the community as a whole and the healthcare provider and others that may be trying to coordinate care for the patient can see that there was a referral, and they can make sure that that referral was actually fulfilled and that the person got housing assistance or utility assistance, et cetera. And you can track that over time, and you can really, when we have that system in place, we will, in addition to having clinical information on an individual, we will have social determinants information. You can bring those things together and really analyze larger data sets to be able to identify gaps that exist in the communities, what those subset populations are, and then be able to match that up with different programs and initiatives to really address, health disparities, advance health equity, et cetera.
Wow. And are those resources that are out there able to dance to provide?
I think that's going to be one of the questions. A capacity question is definitely one we discuss often. So it's one thing. What we've seen actually, I've participated on an advisory board with a program that Dignity Health has, and they actually have a grant where they have actually implemented a much smaller initiative, but something similar, where they do assessments either in the emergency department or in some of the family health centers of Valleywise and some other organizations. And if there is a social risk factor that's identified, they have a similar pilot program where they make referrals. And it's one thing to have the system that can make the referrals. That's one piece of the puzzle that's missing. But if you have the system that can make the referrals, the question is, if we got really efficient at that, is there enough capacity on the other side of, fulfilling the referrals? I think we are going to actually, through this process, identify what the capacity needs are and have to work as a community to determine how that gets addressed when there is lack of capacity in certain areas.
Look at our homeless situation. Pedro, you deal with social determinants of health every day. How does your organization help individuals move forward into filling the needs that they have?
Yeah, so much to what Melissa described, we are also facing similar barriers, I guess, in the need, or seeing the need that there needs to be additional resources for our communities, because we are an FQHC and definitely we connect individuals to resources. But we also need to be able to grow and develop those resources either in-house or being able to have partners that have that capacity to provide to our community members or patients so that they can continue to receive that support from a social determinant perspective. But it definitely is a huge issue that I know that over time we will begin to overcome, and the pandemic has exposed that even more than what we've already known. For instance, I have employees, unfortunately, that are experiencing food insecurities as well, or issues during the pandemic. And so we are trying to figure out as an organization, how do we even help our own employees, and making sure that at least we're providing those resources to them as well. What's interesting is it's what we don't know and that we need to figure out, right? And so we partnered with a Mayo Clinic on a pilot study to really address and working on assessing individuals that have been impacted with COVID-19 and seeing what additional needs that they're seeing that they need during this pandemic, and then how do we fill in those gaps. So there's still a lot of work to be done around that, and we need to get better as an organization and as a community to continue to provide those social determinant of health resources.
It's tough. Affordable housing basically is an oxymoron.
Just got less affordable.
Right. Isn't that the truth? So I appreciate that, having worked with homeless organizations over the past number of years, how very, very frustrating it can be to try to get hope into people and then, deal with reality. Do we have the systems in place for, so obviously these things end up in the legislature to deal with. Melissa, do you deal with the legislature? Do you advocate on public policy?
Yes, we do. We are a 501c3 nonprofit, so that activity and advocacy is fairly minimal. So we're not a 501c6 or an organization that does more robust advocacy, but we certainly fulfill a couple different roles. We provide information and education to legislatures on the topics that we cover on a regular basis. And then we do really lobby for changes to legislation as it relates to supporting more robust health information exchange for the community. Right now, we are working with the legislature on legislation in collaboration with the Department of Health Services and Access to make some changes to both the communicable disease statute and to the immunization registry statute specific to COVID. So in the COVID environment, it's been really great that we have a foundation for health information exchange, because even without having a connection to the Department of Health Services that could send us all COVID lab results that were reported in, we were already getting, because of our connections with Sonora Quest, all the hospitals and other labs, we were already getting 70 to 80% of all the COVID lab test results just because of our current connections. So in the first couple weeks of the pandemic, within a matter of a week, we translated that type of real-time alerting system that I mentioned to you around hospital admissions and discharges. And we started providing real-time alerts to, hundreds of healthcare providers and healthcare organizations when the patients that they treat were came back with a COVID lab test result, whether it was positive or negative. And then we later added alerts for antibody tests to those. We created some very unique structures with hospitals where the moment somebody walked into the emergency department, their system would ping us and tell, if I walked in the emergency department, a message would come over to the HIE and say, Melissa's in, Valleywise ED. Our system would query everything that we have and say, do we have any information that Melissa's had a COVID test and what were the results? Package up those results into a report and push it back into Valleywise's electronic health record, so that within minutes they knew if I was presenting somewhere and I had a COVID test recently and what the results were. We worked with all the major hospitals in Maricopa County to actually develop that specialized system, because one of the challenges that we have in public health, and this is what, back to the legislative question I'm getting to, is that data is flowing as mandated by statute to go into public health for public health reporting. But the connections are not there for the public health departments to get all that information out to the healthcare delivery system so that they can access it as well. So what we're actually changing in legislation now is, we were in a pretty good position to provide those COVID alerts, but it would have been nice if we had 100% of COVID alerts, which only would have been possible likely if we either had mandated lab results to the HIE, or if we were able to have the public health department send that data to the HIE and we can help distribute it out to the community. So we actually work collaboratively with public health, and they want to be able to do it, but there's statutory barriers. So we have legislation that's going through right now that actually removes those statutory barriers, that allows communicable disease information to be shared with the HIE, and the same with the immunization registry. So we're hoping that legislation gets passed and signed by the governor in the next couple of weeks. And then we will be working with the Department of Health Services to receive a push of COVID vaccine data, so that we can then inform healthcare providers that their patients have been vaccinated, or who of their patients have not been vaccinated. Because today, I've had large hospital systems in our county call me and say they have no insight into who has had the vaccine and who hasn't, because it's all going into the registry, and they can query the registry one patient at a time, but to be able to see your population as a whole is just not a functionality that's possible. And so the Department of Health is very interested to collaborate with us so that they can get us that information and we can be the conduit to get it out to the healthcare community.
Does that include Maricopa County Department of Health?
Maricopa County Department of Health is also a participant in the HIE. So it would include basically all vaccines that are administered, whether they're at a state site, a county site, or pharmacies. I believe everything except for tribes that might be reporting through Indian Health Services are mandated to report to the immunization registry. So we just need one pipe from the immunization registry to the HIE, and it will capture all the vaccines that are being administered statewide.
Wow. So Pedro, you're administering vaccines, yes?
No, I am. If I may, Scott, I just wanted to kind of piggyback on what Melissa was saying. So she had mentioned, being the HIE and getting all the information of folks that are coming into their system that have tested positive or negative for COVID. So we are on the other end, get that information. We get the pings from HealthCurrent, and saying of our patients, our 75,000 patients and others within our system that that have either tested positive, and then so our population health folks immediately go to work on calling them, following up, making sure that they have all the information they need for next steps and so forth. Readdressing, just making sure that they're social distancing, staying isolated, quarantined, and also following up, after they've reached that period, with additional follow-up care, to ensure that their health is in order, because there's a lot of after effects, when somebody has been
right. Pedro, does that mean you do contact tracing?
Not necessarily contact tracing, because that's a whole
I was
different
concerned.
yeah, no. But in terms
I mean,
of,
I was hopeful, but I was concerned.
yes. Well, and I know that there's groups out there that are doing contact tracing where they're contacting everyone that's been in touch with that particular individual that maybe tested positive. But that's not necessarily what we're doing. We're actually following up with care on the other side from a healthcare perspective.
Gotcha.
And then you were asking about vaccines?
Yeah. You're administering vaccinations.
No, definitely. So, as a healthcare organization or an FQHC, we received vaccines from the county, our health department here, and have been administering those from the very beginning when it was allotted to us. We also were very fortunate as an FQHC to be one of the 250 under Biden's administration that the FQHCs across the country that were awarded to receive additional vaccinations from the CDC. And so we've been receiving those and getting those out as much as we possibly can into the community. Unfortunately, it's not something we advertise per se, just because a lot of what we're doing right now is making sure that our patients are dosed, and then we're also doing the community events and getting the demographics that's been identified, 65 plus, 55 plus, and getting those out into the community as well.
So do you physically go out into your communities, or do people have to come into your clinics?
So we do both. Right now, we're probably vaccinating at each of our clinics about, anywhere from 100 at each clinic on a weekly basis. And so we have 9 comprehensive sites. It's actually gone up a little bit more. On the weekends, we're doing anywhere from 300 to 500 vaccinations, and in Wickenburg, it's been probably about 100 on average. We've had a couple of weekend events out there, but our goal is to get bigger and go out and do more. Partnering with groups like Equality Health in the future, and with U of A, we're going to be partnering with U of A and getting out into the community in a different way.
That is great. So Melissa, what are you seeing about the vaccinations? Can you put my name in and tell me if I've had both of my vaccinations?
We can't at the Health Information Exchange today unless, for instance, unless you've received a vaccination from a hospital or a health system, or for instance, if Adelante is administering them and they're sending the data to the HIE, we do have limited vaccine information. So I mentioned, because of our data suppliers on the lab side included Sonora Quest and all the hospitals and some other smaller labs, we were getting 70 to 80% of all the COVID results. Because so many of the vaccines are going through state administered sites and county administered sites right now, we're really only getting between 10 and 20% of the vaccine data coming to the HIE now. That's why we need the legislative change, so that 100% of the vaccine data can come from the state, can come into the HIE, and we can make that available to providers. We are, though, looking at some really unique functionality where, similar to Department of Health Services has all their public facing dashboards. We are looking at actually implementing some healthcare community facing dashboards, so that, if Scott, you ran a clinic and you served 2,000 patients, we could actually load your list of 2,000 patients into our system, and you could see dashboards that are specific to the patient population that you serve. You could also see lists of all your patients, and exactly what you're saying. If I was one of your patients, you would see me on that list, and it would say, has Melissa had the vaccine? What type of vaccine? If she had 1 dose or 2 doses? And then what we're going to do is actually cross-reference that with age, with number of chronic conditions, and other types of risk factors so that you can actually start sorting through your patient population. And so if you had it, or if Pedro had the system, you could basically sort through and say, who are my over 75-year-old patients with 3 or more chronic conditions who have not had the vaccine at all? And then you can use that for outreach. And the system's actually it was developed by one of our fellow HIEs on the East Coast. And it basically, you can actually annotate in. So you could call up patient number 1 and say, you know, really would love to get you in for a vaccine. And they say, oh, I'm vaccine hesitant. I'm not going to do it unless I can talk to my doctor. So you could annotate in there that somebody's vaccine hesitant and you need a follow-up call from the doctor to get that patient comfortable with taking the vaccine. So it's going to be a system that healthcare providers and health plans and other HIE participants can really use to better track the status of their populations and be able to conduct outreach, because as I mentioned, I mean, even large hospital systems don't really have clear visibility into their population as a whole and what the vaccine rates are of their population as compared to the population at large.
So are we gathering enough information on patients to be able to deal with social determinants of health on individuals?
I would say not today. It is being gathered, but it's being gathered in an inconsistent way. It's being documented inconsistently, and then it's not being shared universally across the board. So one of the challenges with data sharing and being able to do cool things with healthcare data is you need it to be consistently documented. So it's got to be really documented according to national standards, so that you're not entering, 3 different options for race and ethnicity, and Pedro's entering 6, so they're not really matching up when you start putting them in the same system. So some of the issues around social determinants is, number 1, it's starting to be captured a lot more. The standards really haven't caught up with the effort to capture the data more. So there are some issues with data inconsistency, although it is getting better. And then we need the information to be shared through organizations like ours, the HIE, so you can actually see a community view. So I think that we're, as a community and as a industry, we're focusing on it, and we're developing standards, and we're moving the needle forward. But I still think there's a long way to go. And Pedro can probably speak. I know we've actually talked about before from some of the different assessments that are out there and those types of things as well. So I don't know, Pedro, if you've got
absolutely. I know. Thank you. So we, as an FQHC, the FQHCs across the country created a document called Prepare to gather information on the social determinants of health. But to Melissa's point, it's not being collected. So every health plan requires that information to be gathered in a different way. And maybe utilizing a different database system or their database system, so it becomes very inconsistent. Data is being gathered, but it's inconsistent, to Melissa's point about how do we then begin to utilize that data to, especially if it was going to an HIE, and it would be the most ideal place. What I talked to Melissa about in the past, would be nice if you all coordinated that collaboration with everyone, right? And we changed the system so that we are entering that same data in the exact same way, and it's filtering through the HIE so that we can utilize that across the board to better serve our community.
Well, and that would speak to having to educate and train administrations of healthcare systems.
Well, and I think that we're moving in that direction. I think people are more willing to have these conversations. It's just a matter of us coming to the table and figuring out what that looks like. The good thing is that we are capturing the data, we are utilizing it, whether it's individualized or within the system, because I know that for us, it becomes very important. But if we're capturing something, I was a therapist before I was a CEO, right? And it's almost like when you have information, you gather information, in many cases, we're re-traumatizing our patients by asking them the same information over and over again. And so if there was a way for them to kind of give us that information of their current status, then we're able to help them in that way.
Well, we traumatize people easily. Well, speaking of that, are you seeing an integration to both of you of behavioral health and providers being able to assess the psychological issues with their clients?
I'll let Pedro go first. He's got a lot of experience in this area.
Yeah, and I'm only alive because Pedro is my therapist. So keep going.
Yes. So
Disclaimer.
we are seeing that integration, right, occur, especially in the FQAC world. It is a must and a need, and as well as with many other organizations to really focus on, and we all are seeing it on the news with, during the pandemic, the increase in the social isolation and how that has impacted individuals from a depressive standpoint to other, disorders that are being, recognized and coming forward, through this pandemic, impacting all ages, right? I mean, I don't know if you saw that in California, there was a number of young kiddos that have expressed suicidal ideations or completed those suicidal ideations, and the numbers are huge. And these are under 13-year-olds, right? Where typically that's that range, and so the social isolation is impacting many, and in different ways. And we're seeing that. I mean, there's the reports out now that about the new generation C, in regards to coming through this COVID pandemic, how our kids are growing up and how our community is really being impacted and affected. And to your point, behavioral health aspect, mental health is huge, and we need to continue to address it. We are expanding. I mean, during this pandemic, we reached a point where we were getting outside of our access to care. And the reason why that was occurring is because we're having more individuals come into our system, and we can't fill those therapy slots. And so we reached out and are working with an outside vendor to bring in those therapist specialists, licensed individuals, so that we can continue to expand our program and providing that access to care.
You have Spanish-speaking psychologists and counselors?
Yes, and we're working on expanding, that as well. But I would say the majority of our therapists are English-speaking, but we do have some Spanish-speaking as well.
Yo hablo español. Yo puedo hacer este trabajo. So Melissa, what are you all seeing on the behavioral health integration front?
So I thought it was helpful for Pedro to speak to kind of the implementation on the care delivery side, but we've actually worked in the integrated physical and behavioral health environment for years now. We were involved as some of the integration activity was happening in the movement from the behavioral health department, from the Department of Health Services over to Access, and the integration of physical and behavioral health services under the Medicaid umbrella. It was clear that there was a need to have integrated physical and behavioral health information shared. So actually 5 to 6 years ago, with support from the state and in collaboration with the 3 regional behavioral health authorities in Arizona, we actually developed an integrated HIE program. And we are actually known across our industry as one of the leaders when it comes to integrated physical and behavioral health information, because we did it so long ago. We did everything in compliance with all the federal regulations that puts additional protections on substance use disorder information. And we really work collaboratively with the behavioral health community. So we actually, over the course of 2 years, connected up really 70 to 80 behavioral health providers. We have 111 behavioral health organizations participating today. And we do have a technology structure that can handle the different types of patient consents that are required. I would just note for everybody, there are special protections for certain types of data. So what the challenge is in healthcare technology is that the policies that require patient consent for sharing of certain types of data are decades old, and the technology does not meet the policy requirements. So for instance, if Pedro's clinics offer both primary care, general mental health, and substance use disorder services, very likely, and this isn't anything against Pedro's electronic health record system, but the electronic health record systems are not designed to segregate the data so that you can handle it appropriately with different types of levels of patient consent for sharing. So what happens is all this information is intermingled, and then to be in compliance with all the strict federal regulations, we have to protect it all. So we do have a system that can handle the protections, but because of the way that electronic health records are not able to easily distinguish between data that is protected with additional patient consent requirements and data that isn't, a lot of that data gets intermingled, and more than what's needed has protections on it and requires patient consent because it can't be split apart.
Absolutely correct. 42 CFR is, it's huge, right? In the regulation, and our systems just have that inability to do that, and it's a constant working process.
Yep.
I would think, my sense is that the census, the numbers are increasing in behavioral health issues.
No, absolutely. I mean, undoubtedly, I mean, just to give you an example from just even my own clinic, right? Our therapist went from having 50 individuals on their caseload, and the reason why we had to kind of outsource, some of our impact and our access to care was because, they quickly went up during the pandemic to having over 120 on their caseload.
Wow.
And that happened within months, from April on, right, to August. And so now we're in that process. And when you think about therapists in general in an FQHC world, you really have to have licensed individuals that are paneled with the health plans and so forth in order to be successful with that integration. And so we really had to look at and act quickly on how do we bring more of that resource to our table.
Mm-hmm. So out of curiosity, Melissa, would you have a sense of how many people are single individuals alone, let's say over 60?
I'm not going to know the number off the top of my head, but
No,
yeah.
It's okay.
I think that the challenge is, if you're talking about individuals over 60 and related to social isolation, and do they live alone? Yes, we could probably do that analysis because we have address information. So you'd have to make some assumptions of if you only have information on one patient in a house, they probably live alone. But we do have that type of analytic ability. We also have to always abide by what we call our permitted use policy, which ensures that we meet federal regulations, state regulations, and then really the needs of the community when it comes to how, for what purposes information is accessed through the HIE. So for instance, due to some statutory limitations at the state level, we're not able to do a huge broad scale research with data because of some legislative limitations we're hoping to adjust in the future. But, it depends on whether or not an analysis like that would be being done for care coordination, for treatment, et cetera. But we do have that type of data that we could get that number.
I'll call you tomorrow for that. So any questions from Amanda and Cassandra? Are you all there? Are you there, God? It's me. Oh, we are.
Yeah.
You have
nothing
any questions?
Specific. I think you guys have done a really good job addressing everything and going over all the stuff I had asked you yesterday already, Scott. So you answered all the questions I think that people had sent in as well. So
Scott, I was just going to mention, Scott, one of the things I mentioned earlier is that we were working with the Mayo Clinic on doing some piloting within Adelante on getting information. One of the other projects that they have been working on is going out and doing some community surveying in BIPOC communities. So Black, Indigenous, people of color communities, and getting information as to what are the barriers that that people are experiencing and why they're not or having that hesitancy to get the COVID-19 vaccine. I think that's a huge issue that we've been dealing with and trying to get more information so that we can help our communities get the vaccines, much more readily and engaged. Some of the things that have been mentioned are limited access to technology and computer access, that in regards to, our communities, may not have that technology or may not have Wi-Fi or
Wi-Fi is a big issue.
Or even the speed to get, onto one of these big pod, locations. So we're seeing that a number of our smaller communities or pockets of communities of people of color are not able to access the vaccinations as readily as other members of our community. Just even the not enough vaccines. Now we're getting a little bit more of that, of those vaccines coming into the state, and being, much more readily available. You saw that the state programs or the pods are now opening up, to a weekly instead of monthly, pod availability. So we're experiencing some of that as well. We have the opportunity as an FQHC to receive 4,700 vaccines on a weekly basis. And our goal is to get those out as quickly as we possibly can, so we can continue to get out to those smaller communities and go out to the rural areas. I know for us, we're looking forward to going out to Gila Bend and to continuing to go out to Wickenburg. Amazingly enough, there's a hospital in Wickenburg, but we are the only ones that are providing vaccines in Wickenburg. So
really,
yeah, you probably saw us come out in the news a couple of times in regards to Wickenburg, and we're very fortunate to be able to vaccinate our police department out there, our fire department, and others in the community. So we're continuing to look forward to doing more of that. But I just wanted to continue to highlight some of the issues that our community is having. Limited transportation. Other colleagues, one of our other colleagues, another FQHC, via the Soul, is going out and doing mobile units out into the community and going out to some of these elderly care facilities and doing more of those types of vaccinations. We have Circle the City, who is another sister FQHC, that's taking their mobile units and reaching out to the homeless population out and really getting those folks out there, to either, if they're willing to get a vaccine, and getting those folks out vaccinated. And many folks, have just talked even about, if you're an elderly, individual that is taking care of your grandkids, because in society, we have 3 generations sometimes in the household. And for those folks even to get out and to go to a vaccine, where are they going to get childcare, right, during this time? So that's going to come up, quite a bit as well. And then, just even the fear of the vaccines themselves. I know we held a town hall here at Adelante, and you would be surprised. In the healthcare arena, I have over 640 staff. And in the healthcare arena, many of my staff were even asking the questions like, does the vaccine have a chip in it that's going to track me? And we just need to be able to get that information out and to address the myths that are out there. What people are saying, we know is being said. Our communities hear things and talk about the efficacy of the vaccines, and if is it gonna be helpful to them? What does that look like? Why was it done so quickly? There's a lot of questions that our community has about the vaccine. We need to get, and that's the kind of information that the Mayo Clinic's working on, is how do we gather all this information? There's a number of groups doing this to make sure that we're addressing the needs of the community and getting culturally appropriate information out to that BIPOC community, so that we can address their needs and help them to feel safe to come into the clinics or to a pod center to get the vaccine, because we need to reach herd immunity. And I think the last number I looked at is 20% of the total United States has been vaccinated at least once. And we need to get higher than 60, right, in order for this to happen. And we're just not there yet.
I would also note,
go ahead,
that one of the things, because of some of our collaborations with Access, we're actually supporting with Access support an initiative that Crisis Response Network is going to provide to Medicaid patients. And this is probably not even out there in terms of the general public's knowledge, but essentially Access is going to fund care coordination efforts, because Crisis Response Network is now taking over the management of the call center for the vaccine line. So if you have issues with getting scheduled, if you have concerns with getting things coordinated, you actually call into a call line. It used to be administered by contractors directly by Department of Health Services. Department of Health Services is now going to utilize Crisis Response Network's call center functionality, because they do a great job with the crisis line and other things related to Arizona 211. they're actually going to receive some funds from Access that we've been helping to coordinate that will allow them, if somebody calls into the line and has challenges with transportation, one of the things that Pedro just mentioned, it's a real issue, certainly for the Medicaid population, having less access to transportation. They're actually, you may have seen the announcement, they're able to extend the non-emergent transportation Medicaid benefit to COVID vaccine appointments, but the Crisis Response Network is going to link together Medicaid beneficiaries that will be calling the vaccine line to get help with scheduling their appointment to actually make sure and follow up and make sure that they have their transportation needs met. And if they don't, make sure that they link them with a warm handoff to either their health plan or to their healthcare provider, so that that Medicaid benefit can be extended to them and transportation can be coordinated. So I still think all the things that Pedro said around mobile deployments and things, are all of these things are needed, but we do need to kind of implement multiple strategies to have the best chance of getting populations that may not have easy transportation or have as much flexibility to get to the different pod sites there.
Wow. That's enormous. Pedro.
Yes, sir.
What does Adelante mean?
Adelante, it means going forward, right? So Clínica, when we were founded, we were Clínica Adelante. And so, basically a clinic of the community moving forward, right? Moving our community forward. And have since, dropped the Clínica and our Adelante Healthcare, but, maintaining true to our roots and working with migrant communities, we have really grown as an organization and continue to be a big part of our community.
I want people to know about you. It's a great organization. I have one final question, and then if anybody else, but Melissa, do you capture hypochondria?
If that's a diagnosis code, then yes, sure, we do.
I'm just wondering, if you have people who are repeatedly in the system, you should be suspicious.
That's true. I mean, certainly, one of the things with HIE is that you can actually address individuals who have high rates of emergency department visits. We've had analysis and really through the different alerts we provide. I don't think it's necessarily related to hypochondriacs, but we actually had a community health center in Southern Arizona that did an analysis, and they looked at all the alerts we were sending them for when their patients go to the emergency department, because you've heard of issues where people go to the emergency department even when the clinic down the street might be open. So they did this analysis and they assumed that people were going to the emergency department in the hours when their clinics were closed. No, their patients were going to the emergency department primarily in the hours when their walk-in clinics were open, like blocks down the street. So you can use this data to do analysis to understand how you can better serve your community. And we've also run reports out of the system, high utilizer reports, where you can have, I've heard of organizations that have a few patients that are going to the emergency department 50 plus times a year. So certainly it could fall into the category you're mentioning, or it could be for other reasons. But the point is, there are probably way more effective ways to be treating the issues with different patients with different conditions. I remember our chief business development officer used to run a clinic for seriously mentally ill individuals, and literally they would identify the reason the person was going to the emergency department was because they didn't have an air conditioner at home in the heat of the summer, and it was relief. So you buy an air conditioning unit for someone, and you save tons and tons of money because you're addressing the root of the issue, when really the reason they're going is not necessarily for healthcare. It's for different purposes.
To cool off. Do I see Michelle Barker has a question?
Hi, I do. If this is a question time. Hi, guys.
Hi.
Hey, Melissa, Pedro.
Hi, Michelle.
Nice
Hello.
to hear you. I have a question that's COVID related, not necessarily vaccine related. With the onset of COVID, telehealth became a significant means of providing healthcare or increasing access to healthcare during those really difficult times. And the research has shown that people love telehealth care services. However, most of the research is directed at more affluent or more educated or communities that aren't traditionally underserved or more vulnerable. So there is a lack of information about that particular community and access to telehealth services. So I was wondering, my question is two-part for Pedro. Have you seen telehealth influence the way that you deliver healthcare? And are the resources available for your communities to overcome some of those social determinants? And for Melissa, are you seeing telehealth as part of what you're collecting and how that's influencing the data?
Oh, yes, absolutely. That's a great question. So it definitely needs to be addressed, right? We changed our way of doing business during COVID, and it is telehealth. We had to evolve early in March and April and really pivot to moving to a telehealth model. But to that point, the question you asked is, are our communities able to access or utilize this system? And the answer is yes. And the reason being is because most individuals, regardless of income, in today's age, has a cell phone of some sort. And so we're able to utilize that technology, to continue with the telehealth medicine. Are there gaps? Yes, we definitely need to address what do we need to do to increase that capacity. But the utilization has definitely gone up. Most of our providers within Adelante are on some kind of telehealth platform because we utilize a certain EHR. Next Gen, we have the Ottawa system, and it's been great for us in our providers to utilize this system and our patients. But we definitely need to continue to increase what that is. And I think from a federal government perspective, there was a concern prior to COVID to really open up the gates around telehealth because of the potential that it could bring in regards to fraud. But we're not seeing any of that. It's I think the government is seeing that too, and why telehealth is going to be forever change the industry of medicine.
Great, thank you, Pedro.
From a telehealth standpoint, Michelle, we certainly, that is a critical technology component to making sure that there's different options for care to be delivered. Of course, I think everybody knows it exploded during COVID, so it'll be interesting to track kind of how it becomes part of our regular care delivery system. When it comes to information sharing, we typically connect to electronic health records, but I certainly have been giving kind of thought to, in this new paradigm, are there additional types of systems that we need to connect to? Because my assumption is that when people have a telehealth visit, and maybe Pedro can even validate this, you have the system that you use to connect with the patient, like we are connecting now to have the visit. But then typically you would document the visit in your electronic health record, so that information would still be captured and brought over to the HIE through the electronic health record. But I am aware of HIEs across the country that have actually partnered with telehealth vendors and have offered additional support and connected services. So it's something we could look into for the future. It's not something we're doing actively now. The other thing that I've been in conversations with Medicaid about is just how we can be innovative in making sure that, the patients that need support and telehealth services that don't have the devices and the connectivity to access those services can get them. I haven't come up with an easy answer for that, but certainly I'm all ears in terms of ideas, because short of, buying either relatively disposable devices or buying devices and offering them out to, the populations that need them, I've tried to be, just on behalf of some initial conversations we had with Medicaid, tried to think creatively about how can you get the connectivity and the device to the person that needs it so they can use it to be connected to their healthcare provider in a telemedicine environment. So I don't have an answer, but it is something that's come up in conversation.
So Melissa, I was gonna, piggyback on that and just say some of the things that we are working on from a telehealth perspective is individuals that we know are having trouble, with transportation coming into our clinics, or even experiencing everything you just mentioned by not having the capacity to. We're working on partnering and piloting other programs for remote monitoring. Right, we've been fortunate to get some grants around our hypertension, folks that. And our diabetes folks that we need to really engage much more and that don't have that capacity to come in. The beauty of some of the folks that the vendors that we're looking at is that they're providing the tablets with the Wi-Fi connectivity to access that connectivity to the devices that we're using to either take the blood pressure, to gather information on A1C. And so that's being transmitted directly into our EHR and our system, and then we're able to gather that information. But the beauty of it is if they're being provided that tablet, then they have access to telemedicine as well, because then they're able to use that same tablet to do that particular function. So we're looking to grow that and see what that looks like for us. But we're definitely in that process.
So you mean it comes with Wi-Fi?
Well, it depends on the vendor you go with. Right? Some of them are using cell phones, some of them are using tablets with Wi-Fi, and of course there's a cost to all that, but we're trying to figure out how do we balance that out and just bring it into our system.
Wi-Fi should become a copay.
Pedro, there's some great research out there on the use of iPads and distributing iPads with 5G or Wi-Fi access that have shown really positive effects on hypertension and on diabetics. I'm working on a telehealth research project now, and part of what I've been looking at has been the influence of telehealth over the last few years. So I'm happy to share any of that with you.
That'd be great.
Have it already, but just in case.
No, that'd be great. Great, more information, the better, right? Because we're all in this process together.
Yeah, absolutely. Thank you for answering my question.
Michelle, you can have my job any day. So Kirk Baxter, I think, is on and wants to ask Pedro a question. Okay. Kirk, do you know how to unmute?
He does. He usually just needs a second. I just asked him to unmute. There he is.
I do know how to unmute. That really was more for your benefit, Scott. But my only question is to Pedro, and the question was, Pedro, how did you summon the resolve to stay on our set when Scott Jacobson claimed you as his therapist?
Well, I figured everyone knew that he was kidding. So.
Kirk, I'd like to see you in the alley afterwards.
Oh.
Oh my gosh. Well, Kirk, thank you for that. We can't even see you, Kirk. You don't even allow us to see your video. Anyway, this has been wonderful. We are so lucky, fortunate to have both of you in our community as leaders, and at a time when the world is imploding. I am curious to one last thing, and that is, has the world changed at all for you since the administration has changed? And are you more or less hopeful?
Very good question.
I don't know. Certainly, I mean, talking about advocacy from a health information exchange standpoint, our national association, which I'm very involved with, really supports and advances a lot of advocacy around the benefits of health information exchange. So really, especially in the pandemic, we have been advocating for leveraging the technology and the foundation and the community efforts that have been built through organizations like ours going forward. I actually think in my industry, health information technology and exchange is a pretty bipartisan issue. So, there certainly is going to be a lot of investment in public health technology infrastructure going forward. That's probably that was gonna happen regardless of whether or not whatever administration it was. So certainly there's different priorities for the different administrations. So we're tracking that. But a lot of the issues we deal with are generally bipartisan. So it's just nuances in maybe which administration supports what types of positioning and then how HIE fits into that. So I wouldn't say huge changes, although, we do track all the different stimulus packages and how that's going to impact what we do and how we can serve the community.
Could you ask the administration that HEAL needs $1 million? That would be wonderful. Thank you very much.
That's really perfect timing, actually, because
Pedro.
as the treasurer of the organization.
Yeah, wait, let Pedro answer first, and then you can bite our ass. Okay, come on.
Well, I was just
Pedro.
gonna add, you mentioned about, the current administration as opposed to the previous administration and any differences. The same, we would continue to do business as usual, but there are some changes that are subtle and definitely needed that needed to happen. You may have not even noticed it or been aware of it, but there was executive orders that were put in place during the previous administration that really hindered us from addressing health equity in the way that we needed to, and we need to continue doing as a country, and then also race equity and inclusion within organizations. And so our current administration dismantled that, reversed that executive order. And so now we're able to have those conversations openly. I'm able to train my staff that way. So it's definitely a plus. But yes, we definitely need to advocate to get $1 million over to HEAL International.
I love you. Thank you guys very much. I just want to say that on April 14th, we will have Dr. Jeffrey Langland and Dr. Katie Stage, naturopathic sort of focus on healing people and dealing with the issues that come out of COVID. It'll be very interesting. So thank you both. I'm going to turn this over to Cassandra Anderson.
Thank you. Melissa, Pedro, thank you both for your contribution today. It's clear that you're making a contribution every day in our community and around health, specifically in underserved communities. And it just makes such a big difference. It's what HEAL is all about. And, as a small organization, we largely volunteer led. We are reliant on donations. So I've posted in the chat an opportunity for that. If you'd like to contribute, that would be wonderful. Alternatively, you can visit healinternational.org and be part of the HEAL community in another way that might meet your needs if a financial donation doesn't. So thank you so much for being here.
We love you guys. Thank you.
Oh, thank you.
Thank you so much.
Bye.
Thank you again, Melissa.
Yeah, good to see you guys. Take care.
All right.
Thanks,
Yes, sir.
everybody.
Kirk, I'll see you in the alley.